Hello everyone, my name is Choong, a respiratory physician and intensivist from the National University Hospital in Singapore. Infection with respiratory syncytial virus or RSV often leads to symptomatic disease, which can present as a mild cold, bronchitis, bronchiolitis, or pneumonia. In this talk, I will share about the different types of RSV vaccines available and explore the existing evidence regarding their efficacy and safety in older adults. By synthesizing this information, clinicians can better understand the benefits and considerations associated with RSV vaccination, ultimately contributing to improved patient care and public health outcomes. These are my disclosures. RSV was first called chimpanzee coryzal agent in 1956, following its discovery during an outbreak investigation into a group of chimpanzees with cold-like symptoms. It was then renamed as RSV after being isolated from human infants with acute respiratory disease. Since then, RSV is now known to affect humans of all ages. Subsequent virology studies showed that RSV is a single-stranded RNA virus categorized into subtypes A and B based on F and G surface protein reactivity. The F protein allows fusion of viral and host cell membranes, forming multinucleated syncytia. Its prefusion structure is crucial for vaccine development due to its conservation between strains and being the primary target of neutralizing antibodies. RSV infection is a global problem and commonly result in seasonal outbreaks in temperate zones, as shown in the left panel. In the Northern Hemisphere, these outbreaks typically happen between October to May. Conversely, in the Southern Hemisphere, outbreaks usually occur from May to September. In tropical and semi-tropical regions like Singapore, shown in the right panel, seasonal outbreaks of RSV are less distinct compared to temperate regions and are often associated with the rainy seasons and humid conditions. RSV commonly attacks the bronchopulmonary epithelium, causing lower respiratory tract disease, airway inflammation, sputum production, cough, bronchospasm, and wheezing. Infection often leads to symptomatic disease, which can present as a mild cold, bronchitis, bronchiolitis, or pneumonia. Active population-based surveillance for community-acquired pneumonia requiring hospitalization among adults 18 years of age or older in 5 hospitals in the US before the COVID-19 pandemic showed that among about 2,200 adults who had radiographic evidence of pneumonia and specimens available for both bacterial and viral testing, a pathogen was detected in 38%. Among the common causes of community-acquired pneumonia are respiratory viruses, with RSV being one of them as highlighted, contributing to 3% of these overall cases. Data from studies done during the COVID-19 pandemic demonstrated persistence of non-COVID viral causes of severe infection. In this study conducted at Singapore's largest tertiary hospital, the prevalence and causes of viral respiratory infections requiring hospitalization were examined. Among hospitalized inpatients with respiratory symptoms, comprising cough, rhinorrhea, dyspnea, or radiological manifestations compatible with pneumonia on chest imaging, about 1.4% were due to RSV. This proportion is lower than in the US cohorts, given the competing presence of COVID-19 and the inclusion of non-pneumonic cases of lower respiratory tract infection or LRTI. Let's look at how RSV can affect older adults clinically. Madam H, a 64-year-old woman, was admitted with acute respiratory symptoms. She had prior influenza and COVID-19 vaccinations. She also had multiple comorbid conditions including asthma, but these were well controlled and she was community ambulant. Viral polymerase chain reaction testing or PCR testing was done on a nasopharyngeal swab sample, which was positive for respiratory syncytial virus. Compared to a previous chest X-ray, Madam H had a current chest X-ray on admission that did not show any new consolidation or pneumonia. So technically, she had a diagnosis of acute bronchitis. Acute bronchitis usually runs a self-limited and relatively short course, which should be the case for otherwise healthy adults. However, for Madam H, her previously well-controlled asthma became severe, and she required mechanical ventilation and neuromuscular paralysis. She had prolonged wheezing for more than a week and could only be extubated after 11 days on the ventilator. During this time, she developed a non-ST elevation myocardial infarction, acute kidney injury, vocal cord edema, and deconditioning, and was only discharged home after more than a month in hospital. Is it surprising that older adults, especially those with comorbid conditions, suffer a more complicated course? A systematic review of 103 studies published between 2000 and 2019 in developed countries evaluated the disease burden and healthcare utilization associated with RSV in older adults aged more than 60 years and high-risk individuals with comorbidities. The study found that RSV accounted for 4.7 to 7.8% of symptomatic respiratory infections in older adults, with a case fatality proportion of 8.2%. Among high-risk adults, RSV caused about 7 to 7.7% of symptomatic respiratory infections, with a case fatality proportion of 9.9%. The clinical severity of RSV lower respiratory tract infections in older adults is compounded by a high risk of RSV infection in these patients. In absolute terms, RSV contributes to a large burden of lower respiratory tract infection, which includes pneumonia. Data prior to the COVID-19 pandemic demonstrated that RSV caused more than 24 million cases of lower respiratory tract infections and more than 76,000 deaths in 2016. Among older adults aged 70 years or older, RSV caused 2.5 million cases of lower respiratory tract infection, which works out to be about 10% of the total RSV cases. However, there were more than 22,000 deaths, which works out to be about 30% of the total deaths, which represents a disproportionate number of deaths. In addition, notice that RSV is a more serious disease than influenza for both children and adults. Specifically in older adults, although the number of RSV-related lower respiratory tract infections was less than half the number of influenza episodes, the total number of deaths due to RSV was comparable to that for influenza. Supportive therapy is the primary approach for managing lower respiratory tract infection caused by RSV. The role of specific antivirals such as ribavirin is uncertain, though it has been considered for off-label use to prevent progression of RSV upper respiratory tract infection to lower respiratory tract infection in immunocompromised individuals, for example, those with hematopoietic stem cell transplants. Natural infection unfortunately only provides partial and short-lived protection against RSV infection. This study observed 15 adults previously infected with RSV subtype A exposed to homologous virus challenge at different intervals. Within 8 months, about 2/3 were reinfected, and subsequent exposures caused at least a quarter to be infected each time. Higher levels of certain antibodies, specifically neutralizing antibodies and those targeting surface glycoproteins F and G, were associated with increased protection from reinfection. However, even individuals with the highest antibody levels had a 25% risk of reinfection. Given the lack of specific treatment options, especially after lower respiratory tract disease develops, and the partial protection afforded by natural infection, prevention rather than treatment remains key to decreasing the health burden of RSV. As RSV is primarily transmitted by droplets or nasopharyngeal spread and direct contact through the ocular or mucous membrane inoculation, prevention of infection can be done by masking, cough hygiene, hand washing, and avoiding close contact with infected persons. Nosocomial transmission of RSV should be prevented via strict infection control. Fortunately, direct immunization of older adults is possible. Among the many vaccine targets, the pre-fusion structure of the fusion protein is favored as it is highly conserved between RSV A and B subtypes. Two vaccines are currently available for adults aged 60 years and above. A non-adjuvanted bivalent vaccine called Abrysvo, which is the same one used for maternal vaccination, and an adjuvanted non-bivalent vaccine called RSV. Both vaccines are given as a single intramuscular dose and generate antibodies against the pre-fusion structure of the fusion protein. These final formulations achieve a balance of immunogenicity and reactogenicity after both companies studied vaccine candidates of various doses with and without various adjuvants. Both vaccines can also be given safely with the seasonal influenza vaccine without significant loss of immunogenicity of either the RSV or influenza components. The usual endpoint for current clinical trials for RSV vaccination is the relative risk of developing symptomatic lower respiratory tract disease. Using data from a randomized clinical trial, the relative risk is calculated as the ratio of the probability of symptomatic disease in the vaccinated group to the probability of symptomatic disease in the unvaccinated group. Vaccine efficacy, or VE, is then expressed as a percentage by subtracting the relative risk from 1 and then multiplying by 100. I would like to highlight 3 trials, all of which used symptomatic lower respiratory tract disease as the efficacy outcome. Although this does not equate to survival benefit, we have seen from our case study of MenMH that lower respiratory tract infection can result in severe morbidity in older adults, especially those with comorbidity. The first of these trials is the Renoir trial for the non-adjuvanted bivalent vaccine. Here, vaccine efficacy is high at 85% for very symptomatic lower respiratory tract infection. In the second trial for the adjuvanted non-bivalent vaccine called the RSV 006 study, determination of severe RSV-associated lower respiratory tract infection was based on clinical signs or investigator assessment or receipt of supportive therapy. Efficacy against severe RSV LRTI was also high at 94%. The third and final trial, called the Cypress study, investigated a replication-incompetent adenovirus 26 vector encoding the F protein stabilized in pre-fusion conformation. Although vaccine efficacy was also high at up to 80% for symptomatic lower respiratory tract infection, and even though adverse events were mostly mild or moderate in severity, for unclear reasons, development was halted in March 2023. Overall, from the US Centers for Disease Control and Prevention review of the RSV pre-F vaccination trials in older adults, severe adverse events were rare. Nonetheless, rare cases of severe inflammatory neurological events were noted during the review. These events included the Guillain-Barré syndrome, or GBS, Miller-Fisher syndrome, which is a GBS variant, and undifferentiated motosensory axonal polyneuropathy occurring within 42 days post-vaccination. Though these cases could not be definitively linked to RSV vaccination, the review panel highlighted the need for post-marketing surveillance for both safety and real-world effectiveness. 2023 has been the breakthrough year for RSV vaccination, with the publication of pivotal trials leading to authorization of 2 vaccines for vaccination of adults aged 60 years or above. Multiple vaccine platforms are in development for RSV vaccination. These have generally been immunogenic and well tolerated in early trials in healthy participants, though large clinical trials will be required to demonstrate efficacy. For instance, the Conquer RSV trial, examining Moderna's mRNA-based RSV vaccine, enrolled over 37,000 participants 60 years of age and older, and attained its primary efficacy endpoints of preventing symptomatic RSV-associated lower respiratory tract disease. Results regarding the prevention of severe disease are of course anticipated. For vaccination to be considered a success, vaccines need to reach their intended recipients. At a health system level, this objective can be achieved through the implementation of various strategies, which may encompass the following actions. Firstly, including RSV vaccination in global guidelines, especially those focusing on chronic diseases. Secondly, including RSV vaccination in national policies and vaccination schedules. And of course, more data is required with regards to identifying the need and the timing of revaccination. And thirdly, improving access and affordability, especially in the resource-limited countries. Patients, however, may refuse vaccination even if it were made available, which is known as vaccine hesitancy. Vaccine hesitancy is in turn influenced by 3 factors. To overcome a diminished perception of risk, known as complacency, healthcare professionals need to be equipped with adequate knowledge to counsel patients about the burden of RSV disease and the risk factors responsible for severe outcomes. To enhance convenience, healthcare professionals may arrange to co-administer RSV vaccine with the annual influenza shot. Finally, to overcome the lack of confidence with regard to the benefits and risks of vaccination, more data will be needed, especially for key outcomes like RSV-associated hospitalization and mortality, and to allay fears of rare but severe side effects like the inflammatory neurological events. In conclusion, we have learned that RSV exerts a significant impact on the health of older adults. Given the significant mortality and lack of specific antiviral treatments, prevention through vaccination is a crucial strategy for reducing the health burden of RSV infection. Vaccines in older adults are now available in some countries, with ongoing efforts to bring them to more countries. In addition, newer vaccines on different platforms are being developed to provide more alternatives for our patients. Nonetheless, to achieve implementation success, global guidelines and national policies need to include RSV vaccination, and health systems need to ensure affordability and accessibility of RSV vaccines, especially in resource-limited countries. Finally, more data from trials and post-marketing surveillance of RSV vaccines are needed to build confidence in the long-term efficacy and safety of RSV vaccination. I have come to the end of my talk. Thank you for being a great audience and have a wonderful rest of the week ahead.